Centeno, and thanks for joining me today at You've Got the Power. Today we've got an interesting topic. I'm going to focus on type 1A cervical instability, which is where the clavoaxial angle is decreased in flexion. And what's interesting about that topic is it seems to intersect with MECFS and EDS and lots of other parts and pieces of this big universe of craniocervical instability. So we're going to go through that, going to go through some of the science behind that, and hopefully learn a little bit about it all. And then we'll go to questions, as I always do with this show. I'll start with a short presentation, and then we'll go to questions either about this topic or any topic. So again, today we're going to focus on a low clavoaxial angle, or CXA, and how that intersects with EDS and cervical medullary syndrome and MECFS. So let me go ahead and share my screen. And we will get started here. Okay, so the title of today's presentation is the CXA, or clavoaxial angle, EDS, CMS, and MECFS. So lots of kind of a word salad there of different things. EDS, obviously, Ehlers-Danlos or hypermobile EDS, HEDS. CMS, cervical medullary syndrome, and MECFS, myalgic encephalitis, chronic fatigue syndrome. So before we get started, just to go over this again, if you're interested in getting evaluated to see if you've got CCI and a candidate for really any injection-based care, I recommend that you don't go through the call center or fill out a form online. The reason is that our call center is busy with lots of different things, focusing on shoulders and knees and backs. I'm part of a much bigger practice that does lots of different things. And our CCI patients need much more care and attention with regard to all sorts of sophisticated imaging that they've had done, etc. So it's far better to reach out to Carla, my personal assistant, and Carla can go ahead and help you navigate to a telemedicine visit. These are the references for today's talk. As usual, took a long time to do this, but I want to make sure that I can get you this information and we can all digest it and discuss it. So, as you know, we've been discussing that there are many subtypes of CCI. And today we're going to talk about that subtype 1A. So we'll be, let me pull up a pen here for myself. So we'll be focused on this type 1A, which is going to be C0, C1. And as we'll talk about, this involves the clavoaxial angle. So that's a CXA. So if we draw an angle like this, that's the clavoaxial angle, or the CXA. So what is type 1A? Type 1A is when we've got lax ligaments back here and elsewhere, as we'll see, that end up causing this angular skull rotation forward as the patient flexes. And these sorts of patients have a hard time looking down. Now, other kinds of CCI patients can also have a hard time looking down. So that's not pathognomonic for this problem, but they almost all universally state that if they try to do this, they start getting symptoms. And that's because, as we'll see, this clavoaxial angle here, which is that angle that I just outlined, gets so small, starts out small in neutral, gets much smaller in flexion, and that ends up causing some very specific things with regard to the brainstem and upper cervical spinal cord. So this type of CCI is heavily intertwined with CMS, or cervical medullary syndrome. concept there again is we have this clavoaxial angle. That angle goes too low and tends to collapse due to problems with ligaments back here. And the skull rotates forward. And what it does is it drapes the medulla and upper cervical spinal cord over that spot of the dens. This is the dens here of C2. So you can see this spinal cord right here. That's the medulla there, brainstem, and now we're in the upper cervical spinal cord. And you can see it draping over the dens there because that clavoaxial angle ligament collapses in flexion. So in this type of CCI, an upright flexion MRI is extremely helpful. In fact, I just made this diagnosis in a patient who I just saw this morning. We didn't need a DMX for that patient, even though we're going to get one to look at whether or not the alar ligaments are involved in that particular situation. But we were able to get to the concept of instability that he was having just based on the low clavoaxial angle. That particular person also had another issue, type 2A, where his atlantodental interspace opened up due to a weak transverse ligament. So he will need a PICL and not just treatment back there. But the point of that and discussing that with you is at the end of the day, I was able to get there with flexion extension MRI because this is one of those types of CCI that you can diagnose with a cervical flexion extension MRI. So this is really the money shot concept here. And this is actually Dr. Henderson's work, not mine. And what Dr. Henderson did is some finite element modeling of this clavoaxial angle and the lower medulla there and upper cervical spinal cord. And as you can see again, just so you understand, we're talking about this clavoaxial angle, CXA, that goes down like that. The angle is simply measured from here to here. And what generally happens as this decreases, and what you'll see here, this is the amount of stretch on that upper medulla and spinal cord. But as we decrease the clavoaxial angle and we go to 140, we get a bit of stretch happening in this structure here as it sort of starts to get draped over. And then as we go to 130, not that much more stretch, pretty similar. But we get to this 120 range, and now all of a sudden we have, just like we saw in that MRI, we have this upper cervical medulla and upper spinal cord draped over the dens of C2. And this is the dens of C2 here. And so that's causing this stretching pressure. And what they determined in their study was once we get to this 0.2 range, what we're starting to see is some pathologic stretch within that neural structure. So that would explain why these patients, when they look down, have such a hard problem. So if you go backwards on that, 130, 150, and I'm just going to bring it back and forth a couple times so you can, sorry, I'm going back and forth too far. So you can see how that flexion causes that issue, right? So we're at 150 here, 140, 130, 120. Boom, we start to get too much stretch. So important concept that Dr. Henderson, who's a surgeon in this area, pioneered quite some time ago. But it's also helpful for us when we're looking at injection-based care. And we'll go through that in a second. So again, talking about this clavoaxial angle, I'm just keep beating this in because this is the key concept here. And that's the angle between the clivus here. So that's called the clivus, this part of the front of the skull. When we're down here, that's called the basion. So when you're looking at things like BDI and BAI. That's the B in those measurements. But this is clivus. Axial is C2. So it's this angle between the clivus and C2 that we're measuring here. And again, as we talked about, as the head goes forward, when the ligaments back here are messed up, what we get is this angle gets smaller, and the spinal cord and upper spinal cord and medulla start getting draped over the dens. So at what CXA should we see there's a problem? And that's kind of an interesting issue because as any of you know me, I generally am that kind of guy that will go and dissect the research to answer this question before I'll just take it at face value from somebody else. So that's what I've done here. And so I took these major studies in this area. These are all clivo-axial angles, and this looks maybe a little bit confusing. You know, Batista looked at 100 CT scans in neutral, and this was the mean for normal patients. And this guy looked at 10 healthy volunteers with MRI, and this guy looked at 65 headache patients and 65 controlled patients. And Henderson's finite element analysis showed us that 120 inflection was a problem. We just reviewed that. But the bottom line is, when you look at all of this stuff, the numbers that you come up with in neutral are between 130 and 135 CXA is where you start to get concerned. If you use the 135 number, you're going to have some normals in there who have no problems, and you're going to get a misdiagnosis every once in a while, not very often, maybe 5% of the time. If you use the 130 number, it's very unlikely that you're going to include someone who's normal in there. So took all that part, put it back together, and those are the numbers to remember when we're talking about that CXA. So again, this particular conference, way back in 2013 in New York, came up with 135 as a CXA. And that's okay. About 5% of the patients in there are going to be normal. 95% won't. So I tend to go a little bit lower than that, but it's a similar concept. Now, the normal treatment for this is occipital cervical fusion, right? You want to make sure, since the skull is doing too much of that, a C1, C2 fusion is not going to help you very much, because if you put the screws up through the C1, C2 joints, that's only going to stop C1, C2. And this is an issue that's happening at C0, C1. So it's not happening at C0, C2. So you're going to need to fuse the skull to C2 or the skull to C1. Now, it's a lot harder to fuse the skull to C1. Hence, usually what happens is the skull gets fused to C2. So how can you treat this CCI type 1A without fusion? So let's just talk a little bit about the ligaments here that would be targeted. So remember, what we're trying to prevent is excessive forward rotation of the skull. And which ligaments control that? We've got the nuchal ligament, which you can inject under ultrasound. So that's an easy one to inject. You've got the VDL ligament just below it, which you can inject under ultrasound. So that's not a hard one to inject. That's called the vertebrodural ligament. And then you'd probably want to get these supraspinous, interspinous ligaments all the way down. Now, the one that's harder to inject, and this is one I just did yesterday in a patient, is this PAOM. That you've got to have fluoroscopy and pretty good fluoroscopy skills with contrast to do safely, because, and I'll show you why, it's located deep right in here. So that one's not so simple. Now, if you had this kind of problem, you could certainly try, some simple ultrasound guided prolo into these ligaments and see if you get better. If you don't, then you're going to need a much more detailed injection of that PAOM. And there's another structure involved here too that we'll talk about. So this is my my diagram here. This is the front. This is the back, and this was when this vertebral dural ligament was discovered, and that's the ligament between C1 and C2 where the fibers go front back. So we're going to want to inject this nuchal ligament. We're going to want to inject this vertebral dural ligament. We're going to want to inject the supraspinous, interspinous down here. Those are all easy to do, but where it gets really hard is the PAOM. And that's because the PAOM is bound to the dura. The dura is right in front, the PAOM is in the back. So you really can't do this under ultrasound because you've got no sense under ultrasound of how deep you are here. You don't want to go too deep because you don't want to inject the dura because that's pain sensitive. So you've got to place a needle very carefully under fluoroscopy guidance into this area and not any deeper, and look for contrast flow along the PAOM. And then once you know that you're safe, you can inject. Now notice that we have this rectus capitis posterior minor muscle there, and that's going to come into play next. But before we get there, we'll talk a little bit about the C0-C1 facet joint. Because remember, if the head is going like this, then this is C0, which is attached to the skull. So what we're going to see is that joint is going to be canted up a little bit. And we're going to get compression of the joint anterior here. And that's going to cause wear and tear and damage there. So we would want to inject the 0-1 joint. We'd want to inject the posterior capsule on the way out. But we'd also want to put stuff into the 0-1 joint, which requires a lot. It requires fluoroscopy, it requires contrast, and it requires digital subtraction angiography, and a provider that's done this more than 5 or 10 times in their entire career. So the 0-1 often needs treatment as well. That's the facet joint at 0-1. So C0, C1 here. Now, so we've talked about a couple of structures here, right? We talked about the nuchal ligament, the VDL, supraspinous, interspinous ligaments, the PAOM, the C0, C1 facet joint. But now we got these little guys to worry about. And that's the rectus capitis posterior minor, rectus capitis posterior major. Because remember, if the skull goes this way, what's going to happen to these two muscles? They're going to get stretched, right? They're going to be understretched, and they're not going to be happy. They're going to be holding on for their dear lives. Now, rectus capitis posterior minor is pretty important because it jacks into the dura. And the dura is the covering of the spinal cord and brain. So if it's yanking on the dura, that's going to cause a massive headache. So not only do we have to get some of the loads off of this by tightening up all this stuff in the back and treat the 0-1 facet joint often, but we've also got to treat these guys because they're going to be in fulminant tendinopathy and chronically pissed off. And that's an injection that can be done either under ultrasound or fluoroscopy, but it's again a tough one, right? Because this one jacks into the dura, so you've got to make sure that you inject it in the right place. So the goal of this treatment, therefore, is to improve the CXA when you're looking down, reduce irritation of the upper spinal cord and medulla, inflection, because that's usually when it's happening. So if you can tighten this back here, you can reduce that collapse of the CXA and reduce that pulling on the rectus capitis posterior minor, which is probably not happy because of this rotation, and also help that battered C0, C1 facet joint. So if we sort of map out on the CCI injection procedure levels, the nuchal ligament, pretty easy one to do, not hard to do. You can also do the VDL at the same time, supraspinous, interspinous ligaments as well. But the C0, C1 facet joint regrettably is hard to do. And as I've always said, there's really only one clinic on the face of the earth, and that's in Colorado, that's done this thousands of times. There are a couple of clinics out there that might have done it 50 to 100 times. And then the rest of it, even skilled interventional providers have done that less than 50 times. So, and the reason why is the vertebral artery is close to this. So you've got to have digital subtraction angiography, and that's a special thing that you only usually find on C-arms or fluoroscopy machines that are used in cardiology, but you've got to have it on one used in interventional pain. And then we've got the PAOM, rectus capitis posterior minor, it should be an R, and that's going to be more of a level 4 procedure. Now, none of these patients, unless they've also got other issues like transverse ligament, like the guy did I talked to this morning, need a level 5 PICL procedure. It can be done short of that, but there's still considerable expertise needed. So remember the high quality CCI treatment mantra. What type of CCI do you have? Which specific ligaments need to be injected or other structures? And is the injection you have planned for that capable of accurately targeting all of those structures? And again, I'll close with the same concept. If you're interested in getting evaluated to see if you got CCI, you're a candidate for PICL or other injection-based treatment, I don't recommend that you go through our call center because they're all dealing with shoulders and knees and backs and other things. And many CCI patients have extremely complex imaging that they want me to take a look at. So instead, please email my assistant, Carla, at ksalas@Centeno-Schultz.com. So let's go to Q&A here. I will stop sharing. And we'll get out of that presentation. Okay, so lots of questions here. Let's start. Rhonda, are there certain days of the week that you perform the PICL treatment? Usually, Rhonda, for me, Tuesdays and Wednesdays is when I perform PICL. Daniel, as primary care doctor or a primary care doctor, suggested that I take a DHEA supplement. Are there any risks in stem cells? No. It's actually, that's a good distinction to make, or at least discussion to have. The difference between a sex steroid, so DHEA is a testosterone precursor, and a corticosteroid. A corticosteroid is an anti-inflammatory. So a sex steroid precursor like DHEA is not a problem. Ulysses, is it true if you don't fix your low back on time, then your hips start getting arthritis? Ulysses, I think you bring up an important point, and that is that if you let instability go for a long period of time, or you let muscles misfire around the joint for long enough, it will eventually cause enough wear and tear in the joint to cause issues like arthritis. Ulysses, does CMS have the same symptoms for spinal cord compression? Realize that CMS, or cervical medullary syndrome, is really dealing with the very highest part of the cervical spinal cord and then the lower part of the brainstem. So those symptoms are going to be a little bit different than spinal cord compression much lower down. So for instance, if you got 5-6 spinal cord compression, you might have numbness in your arms and hands. The numbness might be worse in your thumbs, part of your hands, whereas pressure in this area is going to cause much different symptoms than that. Might cause some random body stuff, but it's also going to cause dizziness, imbalance, a general sense of not feeling well. So a little different. Stephanie, on DMX, my C1 vertebra moves with my skull when I nod as opposed to staying still. It's almost like a seesaw type movement with the skull, top vertebra moving as one unit. Yes, Stephanie, so that's an interesting one to look at. That'd be an interesting one to look at the clavoaxial angle on, like we talked about today. It'd also be an interesting one to look at whether or not there's a problem with the anterior ligaments here between the atlas and the skull. So for example, in patients who have that, which is a type 1B instability, when they're bringing their head back, those ligaments are failing. So they're, instead of their skull and their atlas moving as one, what we tend to see is the skull bangs into the back of the atlas with extension. Stephanie was wondering if there's something you've observed before. Can't seem to find anyone else with a similar mobility pattern. Yeah, so the things to look for there would be the ligaments we talked about today, and also the ligaments in the front between the atlas and the skull. Stephanie, and of course, what is the mechanism behind loud clunking upon rotation? Is it that C2 smacking to C1? Yeah, the clunking can generally come from C1, C2. Realize that as you rotate, your body tries to keep the biconvex joint of C1, C2 as together as possible. Now it rides down a little bit, or rides forward or backwards a little bit, depending on how you're going. But that's controlled by the alar ligament. But if your alar ligament isn't working and you go rotate, it's going to be clunk, clunk, that kind of motion. Rob Long, can there be a case where C3 locks up C2, causes hyperflexion of the skull, causing CXA to drop? You know, Rob, just realize that CXA is also dependent on the position of the spine below. So one of the things you've got to be careful with CXA is, for instance, if you've got a lot of kyphosis in the thoracic spine like this, that can lower CXA. So we always have to look at CXA in context of the rest of the spine. But I think what you're really talking about is maybe some hypomobility at C2-3, causing adjacent segment disease or extra forces at C1-2 or 0-1. It's been advanced by Sherry Scop. I was officially diagnosed with EDS. I've suspected it for years. Does EDS negatively impact PICL results? No, that we've done 2 analyses on that because we have so many EDS patients. And the second analysis was just done a couple months ago. In fact, I'm writing that paper up right now, and showed no big differences between EDS and non-EDS patients. Rhonda, would you briefly explain Chiari 0? Rhonda, there is a video on that one, but I'm obviously happy to explain it. But there is a video out there. If you just type in Chiari 1 on my YouTube channel, that'll come up. You want to be on the live section of the YouTube channel, however. But in essence, Chiari is the concept that the brain, and the back of the brain in particular, hangs low. And you've got a hole in the bottom of the skull, and that the brain is normally above that hole. But in Chiari, it can sink into the hole. Now, a Chiari 0 simply means that the bottom of the back of the brain, called the cerebellum, is just right at a line drawn across the hole. If it dips below that by more than 5 millimeters, that's called a Chiari 1, and then 2, and then 3, as it goes further and further down. Now, a Chiari 0 is pretty common in the normal population. There are people walking around with Chiari 0s who have no problem. But what it means in this context, a craniocervical instability, is like gasoline being thrown on a fire. So, and what I mean by that is that if the brain is already hanging low near that hole in the bottom of the skull, and you've got instability at C0, C1 there, then it's going to get banged into even more than someone whose brain is higher up. So it's not something by itself to be concerned about, but it's only something It's only something to be concerned about in the context of craniocervical instability. Rob, since stem cells react to the environment, if one had calcific at anterior side, can PICL stems be prone to turn to bone rather than heal tissue? Not that we've seen, but it's certainly, I think a bigger concern would be if you've got calcification of those ligaments up there, then obviously this has been going on for a while, and that may affect how something like this works. But I don't have a concern about stem cells turning into bone as much as I have a concern about the fact that your body has tried to stabilize the area, and that can impact, for instance, what we can get into, not get into, the efficiency of being able to inject certain spots, etc. Anya, can I ask if I have this type of instability measurements done by a specialist in a horizontal MRI, but my symptoms don't get worse when I look down? Why might that be? Yeah, so Anya, there's nothing about these measurements that for sure tell you that you have that problem generating symptoms. And that's one of the things that we all need to be really careful of when we look at this kind of stuff. My glasses are a little crooked here, sorry. And we need to be careful with that stuff simply because, you know, there's all sorts of studies out there showing, for instance, in low back and neck MRIs, there are people who have really bad looking MRIs who have zero pain, no problems at all. People who have MRIs that are not that bad who are totally disabled. So the pictures are important, but they're just a piece of the puzzle. So you may have other types of instability causing your symptoms, or you may have injuries to these upper joints causing your symptoms, or nerves, etc. And the fact that you've got a low CXA may not be causing your symptoms. So that's something we'd have to evaluate in more detail. Floyd, hi doctor, sometimes I have trigger points on the right side of the C5-6 spinous processes. When this happens, my nuchal ligament calcification at the C6 level bulges and I experience some dizziness. Now, nuchal ligament is high up. It's only at the very top here, so it's not at C6. Do you mean maybe the supraspinous interspinous ligament, or are you talking about the nuchal ligament at the very top? You need a little more info on that one. Floyd, massaging the trigger point makes both the dizziness and ligament bulging disappear. Have you seen a similar case before? So again, Floyd, I need to know, are we talking about low down at 5-6 or higher up at the base of the skull? Harry Winston, I've recently been told I have MECFS by a naturopath. Have you found that CCI patients with MECFS have more difficulty recovering from PICL procedure than other patients? Yeah, I think the biggest problem is getting a specific diagnosis. So again, you know, MECFS is just a box, right? Just a big old box where people who have similar sets of symptoms find themselves. But I need to know why you're in the box. And if you're in the box because you've got a low CXA beating up on that cord, then this should work very well. But if we can't find why you're in the CCI box, then that might portend a poorer prognosis. So again, MECFS is just a box with people who have 20 different problems find themselves. And we need to know why you're in the MECFS box. And if you're in the MECFS box for type 1A instability or another type of instability, we can generally help. But if we don't know why you're in that box, obviously we don't have a specific diagnosis in which to act on. WW Soft, do you ever see lax ligaments causing nerve function issues originating in the mid to lower back? Sure. Yeah, we do. Denise, White Cotton, have you ever heard of a military neck? The curve of the neck, the channel is going straight, no C-curve. My son is a disabled veteran. When he talked to the doctor, he said they've never heard of it. Could it be called something else? No, it's called a military neck. I mean, it's one of the many names. It's also called loss of cervical lordosis, which means loss of the neck curve. But it is also called a military neck. Now, the question is that causing his symptoms? Yes or no? I don't know. That's you've got to make that diagnosis, meaning just seeing a military neck doesn't mean it's causing symptoms. There is a type of chiropractic out there, chiropractic biophysics, or CBP. If you go to idealspine.com, I think it is, you'll find some of those providers that do that kind of work. So we need to know if the military neck is causing problems, but if we just want to get the military neck treated, that kind of providers specialize in that. Regenics has been advanced by FatGen. Have you treated patients with CCI and CSF leak? How does the patient differentiate between symptoms that both cause these? I think the first question or the second question is good to answer first, and that is, I saw a patient like this this week who, again, on social media was convinced he had a CSF leak. Now, clearly had CCI, no doubt about it. But the question I asked him was, when you go from standing up or even sitting up to lying down, does your headache get dramatically better? Answer was no. When you are lying down, and let's say your headache's better, and you go turn your head, does it get worse? The answer is yes. So not a CSF leak, meaning that a CSF leak gets better when you lie down because it's pressure on that column of water, cerebrospinal fluid. And in general, if you're moving your head around, it's not going to get worse. It's not going to cause a headache because it has nothing to do with that. The headache for a CSF leak is due to low spinal pressure. So that's how you differentiate that. Do we treat CSF leaks? We do. We use a platelet-rich plasma patch and then coagulate the platelet-rich plasma. But again, just realize that not hard to differentiate between the two. Rachel, can something like a Dinerol restore some cervical lordosis? I think it can, Rachel. I think the big question for many of our patients with CCI is whether or not the Dinerol kind of aggravates things. If they've got a lot of instability, I find that many of those patients can't tolerate curve restoration until we get things tightened down. But it's an important component, getting that lordosis back, as I was talking about it with the military neck question. It's been advanced by FatGen. Can calcified styloid not allow you to bend your head or rotate it fully? Yeah, it shouldn't be related to head movement. Just realize that a large portion of the normal population that has no problems has a calcified stylohyoid ligament or other styloid ligament that makes a long styloid. So trying to figure out where the styloid is causing the problems is always difficult. Ultimately, taking the styloid out is the only real way to do it. Rob, Rachel, the Dinerol's use gravity, device needs healthy ligaments. I'll skip over that. That's a good one, Rob. Mark, have you seen C1, C2 counter-rotate, almost rotate in opposition to each other in CCI patients? Yeah, we see it a lot. So again, realize that C1, C2 is a biconvex joint. So you have one convex surface sitting on the other convex surface. And which direction it decides to go, in my case here, that's backwards down the hill or forwards down the hill, is anyone's guess, meaning that might be determined by your anatomy, but it can go in the same direction or it can go in the opposite direction, depending on how lax the ligament is. Now, if there's a lot of ligament laxity, I think it's a 50-50 proposition, obviously depending on how you're set together. But if there's not a lot of ligament laxity, then it'll tend to rotate the same direction as C1 as C2. Andy, does laxity in the PAOM, posterior instability only, cause a heavy head feeling? No, not usually. Usually the heavy head feeling comes from the upper neck muscle atrophy. Realize that you've got muscles here that go in all sorts of directions. that stabilize the bowling ball on the stick. So that takes a lot of muscular energy. And many patients with these upper neck problems, those muscles are clearly atrophied on MRI. It's not hard to see. I could teach a fifth grader how to find MRI evidence of upper cervical atrophy. But once those muscles atrophy, that's what tends to cause that heavy head feeling. Andy, if flexion extension MRI should have evidence of PAOM tear and no buckling, would you even consider injecting the PAOM? We're going to look at functionally what's happening to that clivoaxial angle in order to make that decision. We could also look at what's happening with the widening, if you will, of the back of the spine, upper cervical spine, between the skull C1 and C2. But not if it's not involved, no. Isabella, will you ever consider doing PICL with PRP instead of stem cells? You know, we've only done that once or twice. It just doesn't make a lot of sense to me, meaning we want to put our best foot forward. Bone marrow concentrate is far better. We've demonstrated that in our research on things like knee ACLs in treating ligament tears than PRP is. So as a result, it just doesn't make much sense to me to do that. Stacy, I came in late. What are you injecting and why the facet joints versus the ligaments? Well, Stacy, you may want to go back and watch a little bit. I was talking all about ligaments. I think you came in right at that facet joint part. The facet joint was just having to do with the overload at that joint, but we were talking about ligaments before that, the PAOM, nuchal ligament, VDL ligament, supraspinous, interspinous ligaments. Also talking about, I think maybe after you came in, the rectus capitis, posterior minor, major. Rob, when does the ADI space, or when the ADI space opens up on the upper portion of the C1, C2 joint? Yeah, so Rob, that's more of a transverse ligament issue. I think what you're talking about is a V-shaped ADI where it opens up like that up top. You can also see them when they go like that too. But that's transverse ligament laxity, yes. Jim, have you seen small ligament tears that have been chronic, one or more years old, respond to PRP? Yes. Yeah, we have. Edward, if you don't have EDS, can you damage your transverse ligament just by looking down? That screams too much, or does it have to be more sudden trauma? Usually not, Edward. The way that could happen would be if you had some sort of predisposition to a collagen disorder like EDS or other disorders that affect collagen. But absent that, we're usually looking for some sort of trauma. John, are you licensed to consult in Washington State? A little different concept, John. Practice medicine in Washington State, no, that would require a Washington license. As far as talk to a patient in Washington State, not a problem. So no, I don't practice in Washington State. I'm practicing in Colorado right now. Rachel, Dr. Centeno, you recommended that I take glucosamine and chondroitin before my PICL. I've continued to take it. Are there any supplements that help with collagen, such as glycine, that are also effective? I would continue to take glucosamine, chondroitin, MSM. Those are the three for that function. You can also try taking collagen itself. That's another concept there. Eat a lot of Jell-O, same thing. But as far as you needing to specifically take glycine, I don't believe that will add much. Isabella, when moving head backwards, I hear a clicking sound in the upper cervical spine. What ligament could that be? Yeah, so Isabella, that could be a bunch of different things, but the first thing that comes to my head are the ligaments up front, the AAOL, AAOM, and the tectorial membrane. Those are the ones that go between the skull C1 and C2 up front. Those are the ones that first come to mind. There's some other ones that could be involved, but those are the ones that first come to mind. David, how much can be evaluated with physical exam without extensive imaging? I mean, on a physical exam, we can determine things like, are you getting upper cervical signs, nystagmus, for example, which facet joints are tender and might be involved. So that's good. And we don't really need extensive imaging. We need a regular cervical MRI, and a DMX would also be helpful. So we don't need the $1 million imaging. We don't, many times we don't need a cervical flexion extension MRI, although, like I always say, I'll always take more information rather than less. Many times we don't need all these other complex scans that we look at. We look at lots of different MRAs, CT venograms, brain MRIs with and without contrast, etc. Those aren't really needed to get to a CCI diagnosis. We need a routine cervical MRI and a DMX. Every once in a while, we'll order a specialized upper cervical MRI as a tiebreaker if the regular MRI and the DMX aren't getting us there. John, how would you go about strengthening the multifidus in the cervical spine? Would it be difficult, specifically isolate it to the other layers of muscles being over it? John, that gets to some of the exercises. If you reach out to Carla, my assistant, and I'll put this right here, her email, so it's down here, she can get you the exercises that we have. Now, there are other exercises that you can do, lots of different programs, but we've got one if you want to try to work on that. Regenetics been advanced by Karen Schmidt. Can MECFS cause CCI? More likely caused by my EDS. Yeah, so more EDS causing CCI leading to MECFS. Andy, cervical hypermobility by itself a problem. I have cervical hypermobility but show no signs of instability. Clean flexion extension MRI with normal measurements and very minimal overhang. Not usually, Andy. I would just say keep your muscles strong, keep active, so that you can make sure that those muscles are strong. Because remember, half of the protecting joints and nerves equation is stability through ligaments, and half is stability through muscles. Fascia, fructus capitis and other muscles are stretched or they atrophy and get fatty infiltration as seen on MRI as C2-3 muscles that attach to C2 need to be injected to recover. I don't think it's so much stretching as I think, no one really knows why that atrophy occurs. Is it because there's some injury to those upper neck joints? Is it because there's some injury to the nerves that innervate them? Is it because the muscles themselves get into a state of exhaustion? So no one's 100% sure about that at this point. Darby knows. I've had a few PICL treatments and I'm trying to start physical therapy, but I flared up horrible. At what point in the healing journey is that safe to add in? So Darby, you really want to reach out to your doctor that did the procedure. I don't allow my patients to do physical therapy until we approve it, meaning until we're seeing enough stability. So I'd reach out to the doctor that did that procedure for you. John, why is incorporating rotator cuff strengthening exercises helping my weak neck feeling? Posterior instability is mostly being resolved with PRP. Now I'm focused on exercises. Because the rotator or the shoulders are a base of support for the neck and vice versa. So for instance, when you're doing rotator cuff exercises, you're not just strengthening rotator cuff, you're strengthening the connections that go also from the shoulder blades, for example, into the neck, levator scapula being one of those. So it's going to provide additional neck stability. Now, you bring up a good point. When we see people with shoulder problems and CCI, it's like putting gasoline on the bonfire. So we often treat the shoulder instability at the same time as we treat the CCI. But yeah, I mean, you're training muscles that go between the two. Scalenes would be another one that go from the ribs into the neck. Rhonda, I read your book, CCI and PICL. I was surprised that the list of CCI symptoms did not include heavy head and bobblehead. I did watch my videos on this, but I'm still not clear on the cause of the symptoms. Yeah, so Rhonda, it's those muscles we've been talking about, those upper cervical stabilizing muscles that stabilize the bowling ball on the stick. So that's what's happening there, and that's why people get that symptom. Now, realize that that was just 101 CCI patients that I queried. They didn't use that term, but they may have had those symptoms. They just may not have talked about it. Isabella, do I correctly understand that 4-star treatment can all be hit with posterior and 5-star addition to the PICL? Yes and no. So 4-star treatment could be done by about 5 physicians in the US. 3-star treatment could be done competently by maybe 20 physicians in the US. When we get to 2-star treatment, we're now at hundreds of US physicians. By the time we get to 2-star, we're at hundreds to thousands of US physicians. So not as simple as just posterior, meaning that there is no such thing. And I know that patients will often use that term. I'm getting posterior treatment. What kind of posterior treatment are you getting? Meaning that doesn't make a lot of sense. So let's go over that one, because that one is so critical to understand. That it's because I'm seeing people getting scammed left and right who think that, for instance, they're getting their facet joints injected. I had a guy just earlier this week, who was convinced that some neurologist injected his facet joints at 0-1 and 1-2. And so I said, read me the note. The note didn't document that his facet joints got injected. Let's just put it that way. So again, we're talking about 4-star treatment here. And the 4-star treatment, we're talking about someone who can inject the 0 through 2 facet joints under X-ray guidance with digital subtraction angiography and contrast, and who's done it more than 100 times. So we're down to about maybe 5 US physicians who can do that and who are in that category. But when it comes to injecting PAOM and rectus capitis posterior minor, we got to take that down to about 3 US physicians, and they're all in Colorado. This would be PICL here. Now, when we get to injecting C0, C1 facet joints, like we talked about here, again, about 5 US physicians who have injected those joints more than 100 times and have all of that stuff together. Then we get down to 2-star treatment. This is where it really starts to open up a lot. Now we're at maybe doing this with PRP, 300 US physicians who do that. And by the time we get down here, maybe we're at 1,000 US physicians. All of this is posterior, but not able to be done by the average guy down the street doing prolotherapy. Okay, let me get out of that. We'll go back to questions here. Rob, follow up on stem to bone calcium. If it is the ligament that has been calcified, can that be affected if stem cells are injected around it? Yeah, it's usually not the whole ligament that turns to bone, and there's a couple different levels there. So there's some calcium in the ligament. There's bone replacement of a ligament. So I saw that today in some of my telemedicines in one patient. It's being done by the body to stabilize, but realize it can affect where we need to go because we can't get through the bone. Now, that particular guy had it in such a way where I knew I'd be able to get where I needed to be, and only maybe 10 to 15% of his ligaments were calcified. I haven't seen anyone yet with a calcified, for example, transverse ligament or alar ligament. It tends to happen in the apical dens ligament, sometimes in the AAOL or AAOM ligament. Rhonda, do CCI symptoms commonly get exacerbated when in a seated position? For me, the feeling of head pressure, heavy arm, and other symptoms is much worse. Or come on, when seated, why is this? Yeah, Rhonda, I would need to look at your imaging to comment about that. So I couldn't comment on that off the fly. Floyd, I'm talking about C6 spinous process, so the lower part. Yeah, Floyd, that's a harder one to describe, why you put pressure there, and it helps your dizziness because the dizziness is upper cervical related. Now, what you may be doing is you've got a lax supraspinous interspinous ligament. That's like a big suspension bridge. So it's possible you're putting enough pressure down here to tighten up the ligament, which maybe helps the stability up high. Or maybe there's something specific about your, something on your MRI or DMX that would explain that. I'm certainly happy to take a look. Pia, can you elaborate on why C5-6 area is so prone to degenerative issues? Yeah, it just is. I suspect it happens because it's the interface between the neck, the much more mobile neck, and the much less mobile thoracic spine. Isabella, does loss of curvature in the neck, for example, the military curve, mean the ligaments are unstable? Usually not. Now, the ligaments have to be stretched out to allow it. So tightening the ligaments through injection can help, but you've also got to start working on getting that curve back. Rachel, there's a chemical metabolic signature at MECFS. This one is probably diagnosed. It's more than just a box. Yeah, but it's a big box that has that, meaning that what we're talking about there is mitochondrial function. Or more recently, there was a paper on gut microbiome. But, for example, let's go through that for a second. So let's just talk about mitochondrial exhaustion. Mitochondrial exhaustion would occur 100 different ways, not just one. Or let's talk about, changes to gut microbiome. Change to gut microbiome can happen due to vagal nerve irritation, can happen due to taking an antibiotic, et cetera, et cetera. There's 1,000 different ways to change your gut microbiome. So we've got a box, and yes, it's got some generalized things that seem to be associated with the people in the box, but the cause of why those are happening is much more interesting than just finding that there's a change in the gut microbiome. Meaning that if you restore the gut microbiome, some of those people will get better. Some of those people won't change at all. All you kind of found was something associated with something else, not a causal relationship. Damien, hi, Centeno. When will we be on vacation? When do you plan on retiring? I want to schedule a meeting with you. I've been in Virginia, Tampa Bay, and Miami, but my pain and function don't improve. It's getting costly. Yeah, so I will be out from April 23rd to June 3rd. And as far as retiring, no time soon. So I think you're good there. That's to Denise. Fat Jen, can a strong massage of the neck damage other cervical ligaments? Generally not. So guys, I have to leave at 2 today. So I'm coming up on 2 my time. So I'm going to just start going through some ones that I haven't covered before. When it comes to GI motility issues, there's the way to determine whether the cause is the mid, low back versus the neck. Not really, not any way that I know of. Any link between malnutrition, malabsorption, and poor maintenance of ligaments. Again, we've certainly seen malnourished patients that seem to have issues with the vagus nerve and GI motility problems. But as far as saying that the maintenance of ligaments causes that, that would be a different thing altogether. Yeah, I don't know that I can answer that question. I think I got a bunch more. Okay, guys. Thank you so much today. I do have to get going. I've got a sharp 2 p.m. meeting I've got to attend. So what we talked about today was the relationship between that low CXA and the abuse, if you will, of the upper cervical spinal cord and medulla that can happen due to it getting draped over the dens, and that type of 1A instability that's associated with, and the ligaments that are associated with that, the joint 01 that's associated with that, the muscles are associated with that, etc. So thanks so much for watching today. I will be here on Monday. I think on Monday we may leave this topic for a minute. I'll come back to all these different types of instability probably on Friday, but on Monday I may cover the differences between different sorts of stem cell treatments that are out there, because I think I get a lot of those questions. I just had one email to me this week. So you all have a wonderful weekend. Thank you for your great questions today. I will see you on Monday. Thank you.